Good afternoon. I'm Christine Coe, and I'm going to talk about rescuing p53 to treat cancer. I work with a team including a medicinal chemist named Dr. Golani at the Yale Center for Molecular Discovery. There is great need in skin cancer. 1 in 5 Americans will have skin cancer by age 70. Squamous cell carcinoma, or SCC, is the second most common skin cancer, and the vast majority of SCCs are early stage, generally defined as less than 2 centimeters in diameter. There is no good medical treatment for SCC of early stage, and the medical treatments you've heard of are for late stage lesions, and they're too toxic to use in early stage lesions. So what do we do for early stage SCC? We cut them out, and that works, but it's not the solution, and I'll tell you why. Even for just one SCC, a surgery can be quite disfiguring, and some patients get multiple tumors over time and end up with multiple scars, and the previously associated healing time for those scars, especially on the lower leg, which does not heal quickly or very well. Some patients, especially the transplant patients that I see, and there are 50,000 transplants per year in the US alone, get multiple SCCs at the same time, and it's too difficult for the patient in terms of pain and morbidity, but also patient and physician time to cut them all out at one time. My patients need a better solution. My patients are living this. So even this on your left side, you can see a early stage SCC on the nose. The patient was nervous about getting it cut out, but he did have it cut out, and he was very unhappy with the pain and the healing, and he was really unhappy with the scar. Unfortunately, this cancer recurred, and then he refused to have any further treatment at that time, even though at that point it was past early stage and he would be eligible for other medical treatments. Many lesions at the same time in one patient, shown in the middle and on the right, and the patients ask me, like, how is there enough skin here even to, cut this out? And older skin does heal poorly. So interestingly, what we also know in dermatology is that your body can cure SCC. A minority of SCCs can go away on their own. And this is images from a paper from the 1950s and showing how a cancer can heal with minimal scarring. When we've been studying these lesions, we have shown that differentiation is the mechanism. And in the skin, put simply, differentiation is when the skin forms that dead layer that you basically rub off in the shower. So the summary of the biology of these self-curing cancers is that SRSF3, a splicing protein, is decreased, and p53 beta, a specific isoform of p53, which allows for differentiation, is increased. So put in other words, blocking SRSF3 promotes alternative splicing of p53, the guardian of the genome. So here you can see that SRSF3 directly binds to RNA of p53 and prevents translation of p53 beta. So our heroine is p53 beta. And so if we use an SRSF3 blocker, that is our knight that can get rid of the villain, SRSF3, and rescue p53 beta. So compellingly, oral use of a tool compound, a small molecule SRSF3 blocker called SFI-003, leads to regression, complete regression of colon cancer grafted onto the skin of mice. And we already have provisional IP on localized use of SFI-003 or other SRSF3 blockers. We use that same tool compound in 3 different skin models of SCC and showed that differentiation is increased. And in our organotypic model, you can see on the right that 3 different proteins of differentiation are upregulated with that SRSF3 blocker, our knight. So there's great commercial opportunity here because in addition to SCC, colon cancer, as I showed in that mouse model, but also other systemic cancers also have increased SRSF3. So there's good market expansion opportunity. Our proposed use of funds from the Blavatnik Accelerator will be, we have 11 novel SRSF3 inhibitors, and we have a provisional patent on them already filed, and we would like to use those and look at efficacy of those SRSF3 blockers at nanomolar concentrations. We have already started in vitro testing in a colon cancer cell line to try to find a lead compound among those 11. We would also like to concurrently do X-ray crystallography to co-crystallize SRSF3 and one of these small molecule inhibitors to model a best fit. Thank you.